Our next speaker is Cook County Board President. She is a frequent attendee at City Club of Chicago events, for which we are enormously grateful. She also encourages her leadership team, like the ones I mentioned today, to speak at the City Club, for which we are really enormously grateful. Ladies and gentlemen, Toni Preckwinkle. Madam President. All right, thank you.
Thank you very much. Good afternoon, everybody. Well trained, I like that. Speaking of family, I'd like to have our Cook County folks, the health and hospital system, and the folks from the President's office, and all of our staff stand, please, so we could acknowledge all of you. Come on. A somewhat bigger crew than your blood relatives, Jay. There have been three heads of our hospital system in my 6 years in this job. The first person, as far as I could tell, came here so that he could have a platform to find a job in the private sector. And then there was Dr. Ram Raju, who was a real visionary and who persuaded me that we needed to take advantage of the Affordable Care Act and seek a waiver so we could have our own Medicaid expansion program, and helped launch that. And then was called back to New York. I think he came here in the first place because he didn't have a lot of clout in New York and didn't think that he would ever be head of the hospital system there. But then de Blasio became mayor and called him back, and he went home. And we were blessed to have our third head of our health and hospital system. You know, you have a visionary who has a grand idea, and then there's the poor guy or woman who gets stuck with trying to implement that grand idea. And that is a difficult, complicated task. And I'm very grateful to Jay Shannon and the staff at the health and hospital system for the good work that they've done since we got our waiver in 2013 in trying to implement county care, which is the future of our healthcare system, and manage our health and hospital system. So I'm deeply indebted to Jay and his team, who we will probably acknowledge today, for their good work over the last 4 years, and I want to welcome him warmly to the podium. Thank you very much.
Thank you, Toni, for that warm introduction. And it's a pleasure to be back here talking with you today. I'm here today, and the timing that you had for this couldn't have been conceived at the time that it happened, but the fact that I'm here to talk with you about the Affordable Care Act and the importance of that is luck of the calendar. But it's also a good time to be back because I come about once every year. Most recently, my daughter Kaylee stole my coffee mug from the City Club for her new apartment. So you got to come back at least once. You know, I've been the CEO of the health system for 3 years, and each time that I come, it's to talk about a different page in our storied history. But it's important to recognize that the health system is really one part of a more important overall integrated Cook County support system. It's critical that everyone here understand the importance of the support of President Preckwinkle and the county commissioners for the good that the health system is able to accomplish. I'm particularly grateful for the fact that President Preckwinkle has been a steadfast supporter of the health system when we've had to go out on the hustings, whether it's in Springfield or whether it's in Washington, D.C. She challenges us in the healthcare system to look at everything we do through a lens of social justice, and to perform effectively and efficiently, reminding us that we're working with taxpayer dollars. Her goals have been our goals to implement, and our goals have been hers to challenge at the local, state, and federal level. And again, I'm very grateful for that. Now, I'm also grateful for the support of the Cook County Commissioners who are behind us, because that group, as well as our board of directors, and a number of them are here with us today, are the ones that help set policy and direction for the health system. I'm particularly grateful for the directors who are here today, including Mary Guggenheim, Lila Suleiman Gonzalez, Mary Driscoll, and Sidney Thomas. It's through the efforts of all these people and the incredibly talented people on my team, and I'd like the people on the health system team to please stand up. They are the ones that make us effective. By the way, they all bought a ticket, and they usually don't take a lunch break, so your tax dollars are at work. But they're the ones who are really helping me to move the health system to becoming the integrated healthcare delivery system that we all know is such an important community asset for us. You see, the healthcare system has been around for more than 180 years. It's remarkable to think that it's been around for 38 United States presidents. It's been through 2 world wars and a civil war, our health system. It's seen public health improvements because of modern technologies, antibiotics, vaccines, and the responsible introduction of healthcare reforms such as Medicare and Medicaid that brought the promises and protections of those innovations to vulnerable groups historically left behind: children, seniors, and the poor. We've seen other public health care systems fade into oblivion during my lifetime, but I believe our health system has withstood the test of time simply because of the purity of its mission. It's a mission that's grounded in compassion, altruism, and simple humanity. The mission of this health system knows no political, financial, or religious boundaries. It can be, and it has been challenged by politics, by constraint on financial resources, and even philosophical differences. But it's never strayed from the mission that it determined more than 180 years ago to care for all, regardless of the ability to pay. Whether those all are insured or uninsured, whether they're documented or undocumented, young or old, rich or poor. Now, why has our health care system prevailed when others have not? The answer to that, I believe, lies in part to those of you who are in this room. This is a city and a county that values public health. Leaders that truly appreciate the community asset that a public health care system can be. It lies in a legacy that has shaped modern medicine and in doctors and nurses who recognize that the mission of the health system is bigger than their individual roles. It lies in the system's ability to adapt at the right moments throughout its history to serve the communities we serve. And I can't think of a more important challenge and a need for adaptation than what we're seeing right now as the United States Congress considers repealing the Affordable Care Act. There's no more important moment for us to talk about that. Now, throughout our 180-year history, the health system has been a lot of things to a lot of people. Today, I want to share with you how we're shaping the system so that its mission carries forward long after we're gone, and regardless of what happens this week, this month, or next year in Springfield or in Washington, D.C. Once a system that provided care to those who showed up at our hospital, we're now a system that's focusing on health care and wellness. The shift from expensive, reactive, hospital-based care to the provision of community-based ambulatory and prevention services is largely a response to the Affordable Care Act and state policy to move Medicaid enrollees out of fee-for-service and into managed care. Now, this is a good thing that over time should improve outcomes, lower health care costs, and reduce expensive hospital stays. But I can't stop there, and this talk is going to be a little bit wonky, and the reason that I brought a few slides is that I think it's critically important for the community leaders in this room to be able to spread the knowledge and the awareness of what the public health care system in this county and this country frankly does. Now, make no mistake, the Affordable Care Act has been a godsend both to the patients that we serve and to our health care system, as I've shared with you in my last 2 talks here. I've told you about the impact that it's had on local taxpayers. But I want to refresh for you a little bit because the Affordable Care Act is still pretty new. Now, today, nearly 70% of the people that our health care system serves has insurance. Most of that is Medicaid insurance. Before the ACA, that was less than 1/2 of the people that we served. This means greater access to care for those individuals and less reliance on local taxpayers to cover the cost of those who are uninsured. And let me talk about the uninsured for a minute. In 2013, before the Affordable Care Act, the 72 hospitals in Cook County provided $690 million in charity care. Now, how much of that $690 million do you think that the Cook County system provided? It was $257 million of that, or 37%. So think of that for a minute. 2 hospitals, Stroger and Provident, providing 37% of all the charity care in the county. Now fast forward 2 years, 2015, post-Affordable Care Act. Those same 72 hospitals, because they saw more insured individuals, charity care overall in the county went down by 25% to $522 million. This is what the Affordable Care Act was supposed to do. But our same 2 hospitals in 2015 provided $233 million, or 45% of that charity care in Cook County. Now, I don't tell you that for any other reason than to demonstrate that we walk our talk of our mission. No matter the circumstances, no matter the times, we remain committed to caring for people. And what's been critical to our success and our ability to do that in recent years, though, has been Medicaid. Medicaid has always been important to the health system, but today, following the Affordable Care Act, it's even more important. And I want to walk you through that a little bit right now. So this is a quick history lesson. Bear with me. Here's a nice picture from 1965 as LBJ signs into law Medicare and Medicaid as amendments to the Social Security Act. You can see a great Minnesota legislator in the back there, Hubert Humphrey. You can see the Trumans, happy to see that they're going to have coverage in their dotage. You can see Lady Bird looking almost as good as my wife today. All right? But here's the impact. For the first time in our history, the insurance rates, the uninsured rate in the country fell substantially. Pre-Medicare and Medicaid, it was up in the 25% range, and that included seniors. Now you can see the dramatic drop in the proportion of Americans without insurance following the introduction of Medicare and Medicaid. But unfortunately then, it hits a very stubborn plateau that persisted until the Affordable Care Act. Now, here's a diverse and happy-looking crowd back in the spring of 2010 when President Obama signs into law the Affordable Care Act. And you can see the familiar faces. And I think it was Vice President Joe Biden who characterized this as a big deal. But I want you to understand, lest you think that Medicaid is some kind of scourge, recognize that today, post-ACA, 1 in 5 Americans is covered by Medicaid. And the important thing about this is also a signal for the individual business leaders in this group. Because of the fact that we haven't been able to get incomes up in the country, Medicaid is a necessary safety net. Look at these thresholds for an individual or a family to live on. You make more than that threshold, and you can't get Medicaid. And in states that have embraced the Affordable Care Act, this is where the coverage thresholds are at 138% of the federal poverty level. Above this, you can get into the marketplace, which has problems and it has challenges. But once more, look at what the Affordable Care Act did. It took that number of 47 million Americans, or some 18% of Americans, down to where we are today, where about 11% of Americans do not have insurance. What's been the impact locally? Well, what you can see on the left is that from the time before the Affordable Care Act to post-Affordable Care Act, more than 1 million Illinoisans have gotten insurance. In Cook County, substantial decrease in the number of people who are uninsured, such that today, Cook County and Illinois have about 6% of our residents uninsured, and this is down from the mid-teens before the Affordable Care Act. Now lastly, I want to give you a picture of what we do in our healthcare system. What you see in these pie graphs is the distribution of insurance coverage First, for the country, in the middle, Cook County as a whole, and in the graph to your right, the people that we serve in the Cook County Health and Hospital System. What you can see is that the dominant mode in our country for insurance is employer-sponsored insurance. As I mentioned before, in red, you see about 1 in 5 Americans covered by Medicaid, about 14% covered by Medicare. Now look at the Cook County Health and Hospital System. We're the only hospital system that's trying to shift revenue from Medicaid to cover the uninsured. 50% of the people that we care for have Medicaid. A third of the people we care for have no insurance. And only a very small sliver have private insurance. But again, this is about dollars. It's about proportions of insurance. But really, the key to the Affordable Care Act is people. And what I want to talk about today is some people. And we're happy that we've got 3 county care members who are brave enough souls to share the transformative effect of the Affordable Care Act with you. And these are real lives, real people who contribute to our communities. Now, on your left, you see Earl. He was diagnosed with diabetes in 2002. This 60-year-old Bronzeville resident said he still finds it scary to think what his life would have been like without health insurance, and therefore without the means to pay for medication and the doctor visits that he needs to keep his diabetes under control. He told us, "I don't even want to think about that because I don't know how I would have survived," noting the many complications that can arise when diabetes is not properly cared for, like losing your eyesight, your kidney function, or a foot. With county care, Earl has been able to get a primary care home and keep his diabetes under control, something he's grateful for. Earl estimated that the medication that he takes for his diabetes alone would have cost him close to $1,000 a month, something he would never have been able to pay for out of pocket. As he says, "You'll do whatever you can to stay alive. So I'd find a way to pay for that medicine and those doctor visits. But without Medicaid, that'd be kind of rough." This is an understatement, Earl. He added, "Everybody should be able to have some kind of insurance. We're more like a third world country when it comes to medical care." Now, because of this, Earl is able to work as a mentor at the Chatham Academy with at-risk youth, where he provides them with life skills that will open doors to good opportunities. Now, Jeanette, who you see in the middle here and is again at our table in the back, is a widow who raised her daughter on her own while running a flower shop in Chicago's Humboldt Park neighborhood, a neighborhood, she says, where people could use some flowers. As a small business owner, Jeanette never bought pricey individual insurance coverage, but she and her daughter were lucky enough to be relatively healthy. Just because we didn't make a lot of money didn't mean we weren't rich in other ways, she reflected. Now, 3 years ago, her daughter was laid off from her management position. Working a part-time job while she searched for a new position, she came down with a severe bout of influenza. It cost her 2 weeks of her life in a hospital, and it almost cost her her life. It was touch and go for a few days. While at the hospital, both Jeanette and her daughter got enrolled in county care, our Medicaid managed care plan. County care was able to cover those costly bills, which otherwise would have been sent to collections. Jeanette notes that the doctors and nurses saved my daughter's life, but Medicaid saved her future. Today, her daughter has a new job that provides health insurance. Jeanette is still grateful for her county care coverage, and she refers to her care manager as her angel. She adds, "Medicaid isn't about giving benefits to people who are lazy. It's for people who are in need the most. It takes all kinds of people to make the puzzle of our economy work. Even though we didn't make a ton of money, we work as hard as we can, and we have pride." Now, lastly is Margo, that you see here on the right. She's a survivor of domestic abuse, who through the advice of her advocate at the Chicago Department of Family Support Services applied from county care when she was able to escape her abusive relationship. Here's a quote from Margo. "Although my life was turned upside down, I realized that I desperately needed help, both mentally and physically. The psychiatrists and mental health specialists at Heartland Health Outreach recognized that I was critically depressed, to the point of being near suicidal, and that I was suffering from acute PTSD. They prescribed an effective combination of medication and intensive therapy that enabled me to recover from my nightmares. Once I was free of my abusive relationship and covered by Medicaid, I was in a position where I could consult a dermatologist about the small and large spots on my face that had been worrying me for months. These turned out to be cancers. Not only that, but it turned out that my face was covered by precancerous lesions. Through Medicaid coverage, I was prescribed and treated with a 10-week topical chemotherapy treatment that has eradicated all the skin cancers from my face and neck. Earl, Jeanette, Margo, I'd ask you to stand, please. And please join me in thanking them for telling their stories. Now, I want them to know that regardless of what happens, we will be here for you. Now, remember earlier when I said that the key to our success was our ability to adapt. Medicaid has allowed us to do that. It's given us space to adapt. But that adaptation is to improve lives for real people who live in our communities. We've continued to transform to upstream services, identifying and addressing social determinants of health. I just want to give you a couple of examples of that. One is our partnership with the Greater Chicago Food Depository. We were shocked to find out when we started implementing a validated tool that they brought to us that 14% of our adults and almost 22% of the children we were serving were living in households where at the end of the month the cupboard was bare. Partnering with the Food Depository, we now have a program where those individuals are given information about food resources in their community. They're given assistance applying for SNAP benefits, and they get a prescription from their doctor for fresh fruit and produce with the Food Depository's Fresh Truck that visits our clinics. This is moving upstream, and when you're taking care of 40,000 diabetics, and God knows how many people with high blood pressure, diabetes, and heart disease, heart failure and kidney disease, you can't cure that with medicine alone. Some of it has got to be around diet and lifestyle. The impact of those programs can't be underestimated for either the individuals we serve and, frankly, for our staff, who have had to learn to start thinking beyond the clinical moment and thinking about the milieu that our patients live in. And I would point out that the innovation and the thinking about that milieu has also caused us to dwell on and develop innovative strategies for justice-involved populations. Now, I don't need to preach to this particular choir about the societal and the tax costs of taking care of people who are justice-involved. President Preckwinkle, Justice Burke, State's Attorney Kim Fox, Sheriff Dart have all talked about that in this room in the past year. But I do want to commend the President, her Justice Advisory Council, our team in Correctional Health Services, the Sheriff, the State's Attorney, as well as all of our external partners, many of whom are in the room, helping us to improve the lot of these individuals. Just to give you a sense of what that group is doing every year at the Cook County Jail, our health team is conducting 50,000 intake screenings, 60,000 diagnostic tests. Today, they will distribute more than 16,000 doses of medicine. Now, they view the detainees at the jail as their patients, and they treat them the same way that we would treat any of our patients in any of our facilities. They care deeply about these individuals. But they also are moving upstream. Most recently, we're moving upstream with detainees who have opioid addiction problems. We're now training them on how to use the rescue drug naloxone, and we're giving them that at discharge. Because when a person who's addicted to opioids gets out of the jail, they are at extremely high risk from dying from an overdose. Since 2013, through our intake process, we have gotten more than 16,000 individuals who come through intake at the jail into Medicaid. Now, when they are discharged, we can get them into community-based treatment with a medical home and the behavioral health supports that they need. And most recently, we've opened the Community Triage Center in the Roseland community. a place that's staffed with mental health professionals 24/7, 365, to give individuals, families, and the police a therapeutic alternative to taking somebody to the jail. These are just a handful of the strategies in our ongoing transformation to make sure that our 180-year-old system continues to adapt. We continue to invest in our facilities. We've got a new facility coming up in our Stroger campus and one we hope to see coming up to serve the Provident community soon. I'm proud of what we've been able to accomplish, and I'm excited about the future. But this would not have happened without the support of our elected officials, because, as I'll close with, we're once again on the cusp of disaster. So this is Inauguration Day back in January. It's kind of a different vibe in the room, wouldn't you say, to March of 2010? This is the president signing the executive order saying to use budget reconciliation as a means to repeal and replace Obamacare, or the Affordable Care Act. Now, it's important for everybody in this room to know that the approach that's being proposed has a bullseye on reducing the dollars that go into Medicaid. And we in Illinois, we who call Illinois our home, need to know that we're going to be at the bottom of the barrel when it comes to fixed costs for Medicaid. Today, we're the 49th out of 50 states in the spending per Medicaid enrollee, at $5,400 a year, $2,000 below the average across the country. And by the way, the average expenditure for every man, woman, and child in the country is $10,000. Out of all the 50 states, we receive the least amount of federal dollars for our Medicaid program because we are in the bottom tier of federal matching dollars. So this is a gigantic challenge. The projections for what the so-called American Health Care Act would do are dire. The Congressional Budget Office estimates that there would be $880 million in reduced funding for Medicaid over the next 10 years. This would result in 24 million Americans being uninsured in 10 years, with the bulk of that happening the first year that it goes into effect. We would lose matching dollars in a substantial way in 2020, and they've made the redetermination so challenging that it can only be understood as a design to bring down the number of people who are on Medicaid. The Illinois Hospital Association estimates that our state would see a $4 billion hole put in it from federal funds that wouldn't be there for Medicaid, starting next year. So I want you to remember at the end of this that I hope that I've helped you to understand a little bit better the importance of Medicaid. There's a lot about dollars. There are a lot about big statistics for the country and the region. But at the end of the day, this is about caring for people. And I hope that my talk has given you some insights so that you can be advocates for those individuals, because we're going to need all the advocacy that we can get to help us from stepping backwards. The ACA was a step forward. I hope we don't go backward. So thank you again, and I look forward to your questions.
Thank you, Dr. Shannon. Okay, we're ready for questions. So if anybody has any questions, just hold up your blue card. Our staff will collect them and bring them up to me.
Wow.
Wow. Here comes. Thank you, Sarah. Okay, let's see what we have here. It's kind of interesting. Not a single question here about Medicaid and the Health Care Act, a couple of architects and so on. This is from Tripti Singh. Tripti, where are you? Right down here. Glad to have you. Thank you. You're not a member of the City Club. Our staff will corral you on the way out. $35, folks. Tax deductible. Okay. Tripty's with ingenious architecture. She says healthcare trends within the county and at the county, healthcare trends within the county and at the county. I don't understand the question.
Tripty, what's the question?
The question was, I was trying to understand the healthcare trends taking
Yes.
place within the county.
Yes.
And, what the county is really doing to embrace that.
Yes.
Like where we are heading towards, like behavioral medicine,
Yes.
combining that with primary care. And
Sure.
I know you started talking a little bit about it.
Sure.
But if you could give us a little more insight.
Well, so the question was, what trends do we see in healthcare, and what's the county health system doing about that? And she's actually not a shameless plug, but I'll give you the opportunity. If you go to our website and you go to our board governance page, you'll see a link to our 3-year strategic plan, which our board guided us through and adopted last summer. That strategic plan talks about the continued transformation of the health system, particularly with a pivot for moving to community-based services wherever possible, ambulatory services wherever possible, and then a whole raft of different strategies to try to improve the services that we bring. Specifically as it relates to behavioral health, that strategy is built around 4 big pieces. One is integration of behavioral health into primary care. The second is the adoption of evidence-based practices for people with substance use disorders. The third is the development of the Community Triage Center in Roseland, which I told you about. And the fourth is a behavioral health consortium, which we've established. We've got some members from that consortium, from HRDI and other groups that are here with us today. This is a one-stop shop for our providers, where they can pick up the phone, describe a problem that one of our patients has, and then they can be immediately triaged to the most appropriate behavioral health services for them, ideally in a community location that's close to them.
Okay, thank you. And I apologize for not being able to understand your question, but you didn't include the other 100 words in your question. Thanks, Tripty. This is from Steve Bly, who's with Leggett Architects. Considering your proximity to the other hospital systems within the IMD, the Illinois Medical District, how do you balance collaboration with competition?
Well, we have plans to acquire Rush and University of Illinois. We weren't actually going to do the VA because it's a federal. Kidding aside, we collaborate all the time. One of the challenges that the entire ecosystem for healthcare in the region has is that it's been historically based around hospitals, and most of these hospitals are more than 100 years old, and they kind of are where they are, and they were serving who they were serving in a pre-automobile era, in a pre-penicillin era. What we have found, so I first joined the health system in 1990, and we were surrounded completely by public housing. We had all kinds of patients who came to my clinic. They would walk to the clinic, and that has changed. But the buildings, the way that we look at it is that now the Stroger Central Campus is where we try to funnel people who need care of the most technology-dependent, or interdisciplinary, or requires highly skilled technical support for the services that are being there. But otherwise, we're trying to push out into the community. As people are aware, particularly with the changes in public housing over the last 2 decades, there's been a significant diaspora of the communities that we served to the suburbs, and we're trying to think, how can we do that? But one of the things that we've realized in the last 5 years is that the health system can't do it alone. We have to partner not only with community-based organizations, but with other healthcare organizations. At the same time, it's a fact that with the majority of our patients insured, all of a sudden, we are competing for them. Individuals who, when they were uninsured, were shooed away from the doors of these other hospitals are now being welcomed in, and they're trying to make a connection with those folks. So we're trying to improve our services, trying to improve our customer experience, and trying to improve our facilities so that we can continue to compete. Because there is, again, no other system that's anywhere close to us as to the proportion of individuals who we serve who are uninsured. $500 million in care last year. And so if we don't retain our insured patients, the financial underpinnings and strategy for the organization fall apart.
Okay, thank you. This is from Jack Hartman, SDI Presence. With Obamacare being wound down and changed, how will you treat your current patients?
Thanks, Jack. Well, I think we will continue to treat them the way that I hope we always have, that is with compassion, with competence. And by the way, I just want to argue a little bit with the first premise of that question, and that is with the fading away of Obamacare. This has not happened. It is up to the people in this room to be advocates for and to go out and be talking with their elected officials, to be drumming up support with the communities that they serve, to be, as individuals and as civic organizations, to be telling our Congress not to step backwards. And that would still be my position today.
Thank you, Dr. Shannon. This is from one of your old classmates, Mark Weiermuller, St. Ignatius,
Mark.
class of 1978.
Yes. You had to say that.
I did, for Mark's benefit. With declining population in Illinois, how can we increase funding without increasing property and income taxes? You know, he's kind of to the right
Yes.
center.
So this is an important and a difficult and challenging question. I peeled out of the slide deck that I shared with you some important information that I think is driving the macroeconomics behind this. And I'm a doctor, I'm not an economist. But there's an important slide that you can see that over the last 4 decades in this country, we actually have made progress with improving incomes for households across the country. But it hasn't moved hard enough and fast enough. When you look at the fact that today, 1 in 4 individuals in the state of Illinois qualifies for Medicaid because of their household income, the solution to that is not simply pouring more federal dollars in. It's trying to figure out how are we going to fix the economy. And that's going to require, in fact, as much investment in education, in safe communities, in job and skill training for the evolving economy that we're in, such that more people in the county and more people in the state have economic opportunity and incomes such that they, like I would bet every person in this room, almost every person in this room, has employer-based insurance. That would be a terrific thing. So I don't think personally that the solution to this is going to be simply pouring more money into health care. It's got to be, for one thing, and it's a different talk maybe next year, health care in this country is way too expensive. The health care economy is cannibalizing everything else that we need to do in this country. And I think I don't think it's good. It's hard for me to say that as a health care leader, but it's not a good path that we're on. And so I don't think the fix is just pouring more money into the health care economy. I think the fix is fixing our economy and growing our economy so that fewer and fewer people need to rely on the kind of support. That being said, those economies are not going to change in the next few years, and our healthcare system will always be here for the vulnerable populations that may be left behind.
Okay, so that's the topic for next year. You know what that means? Another coffee cup for.
That's all right.
Okay.
I got a big family.
This is from Otto Nichols. With some type of repeal, replace coming, what would be a good outcome? Block grants, etc.
Okay. Well, I think, so the first thing, let me just, again, I'm going to take the opportunity to slightly reframe the question. A lot of what you hear nationally about what's wrong with the Affordable Care Act is focused, in fact, on the individual marketplace health care plans. And they've been challenged because, frankly, the way that it was constructed the first time around, the individual mandate, the teeth in the individual mandate was not strong enough. And so the real problem that those premiums keep going up and up and up is because we haven't got healthy people paying into the risk pool to keep premiums down. So most of the noise that you hear, particularly at the Congress level, has been arguing about the things that are wrong with the individual marketplace. Remember that with the expansion of care under the Affordable Care Act, about 2/3 of the individuals who got new insurance got it through Medicaid expansion. That's our bailiwick. And about 1/3 got it through these private marketplace plans. And it's a shame that the premises that are in the currently being discussed American Health Care Act are counterintuitive to every actuarial insurance principle that exists, as I understand them. And so I do believe that the Affordable Care Act can be improved. We've got to have much stronger inducements for individuals who are younger and healthier to get into the insurance pools. But I do not believe that the proposal that's being discussed right now is going to take us forward in any way. As a matter of fact, and we hope that the Senate will wait to hear the CBO estimates, most people think that the CBO estimates of the current revised HCA under consideration is going to be even more dire than the predictions that I showed you before.
Wow. So I think Senator Collins of Maine said they're going to start from scratch at looking at this bill. Ideally, what would you like to see the new affordable health care bill include?
So, Jay Shannon's wish? My wish would be, first of all, that everyone in the country had health care insurance, first and foremost. Secondly, I think that the new plans have to find ways to assure safe, high-quality care while reducing costs. You know, part of the reason that costs have gone up under the Affordable Care Act is because, frankly, 24 million more people have insurance, and they're getting care. People like the folks that we spoke about today, they are either going to get their care in the emergency room or they're going to get their care in a primary care community home. You know, you make the call about that. But I think innovations in quality, in safety, ways that we can try and find the real drivers of care. If you look at the United States and you compare us to the other developed countries of Europe, you see that we spend about twice as much at a gross level and at a per capita level on health care without the same good outcomes that many of those countries see. Part of that is because there's an imbalance between the amount of money that we flow into health care versus the amount of money that we flow into those other services that support the social determinants of health, housing, education, jobs, those kinds of things. So if you were going to start with a blank slate, health care for everybody, reduce the costs, and improve the quality would be the things that I would hope would be the principles that they would start with.
Okay, remember that for the John J. Shannon health care bill. Our staff member Sarah has a question. The old Cook County Hospital has been abandoned since 2002. What's happening out there?
It's full of ghosts, many have said. So the old county hospital, I'm happy to report, is going to be part of what's being referred to as a marketplace, a market rate development plan. And in partnership, President Preckwinkle's Bureau of Asset Management is partnering with a multi-group private firm to develop the old Cook County Hospital. It will end up being a mixed-use building. We're hoping that the facade will be protected, but in fact, a modern new building will come up that will have residential options, business options, some healthcare use. It's part of a broader development that will include the Pasteur Park to the north of the old Cook County Hospital and then down Wood Street to the southeast of the old Cook County Hospital. It's this kind of robust development that's really transforming the Illinois Medical District and makes it a very exciting place to be. So keep your fingers crossed, but we think that we're going to start seeing construction and movement on that market rate development this summer.
Okay, great. One last question, and then we'll move on. This is from John Davidoff with Davidoff Mission Driven Strategy. How would you rate public health, primary care, and community leadership and their collaborations in Cook County?
Okay, well, I have a sneaking suspicion that the questioner probably has a view on that might be very different from my own. I think we've got a ways to go. It's important to know that if you look on a state-by-state basis right now, Illinois is about in the middle of the pack, and Cook County is about in the middle of the pack. And Erica Salem, who's here and for many years was with the Chicago Health Department, actually used to collect the data that would inform that. And I think that there can be improvement around these things. You know, the reality is, again, that the health of a community is estimated to be driven only perhaps as much as 30 or 35% by the actual healthcare delivery system, the doctors, nurses, and hospitals. To a much greater extent, it's driven by the surroundings, the safety of the neighborhood, the vibrancy of the economy, the robust nature of the education and the jobs that are around. Those are the big drivers, and that's why healthcare delivery systems, hospitals and clinic systems, have to partner with health departments, which can be the sensing organ or the mirror, if you will, of how we're doing, and those community-based organizations that actually know boots on the ground, where to get resources in their community, how to talk to people in the community and make those connections. So I would say, rather than me reflect on it, I would just tell you that the national statistics would suggest that we're in the middle of the pack, so we've got plenty of work to do in that regard.
Okay, and under John, we expect you to be the leader of the pack. I know. Okay, let's give Dr. Shannon a big round of applause.